and welcome to the Davies Use Case webinar being presented by Advocate Health on reducing transcription cost. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. So it's my speaker for today's Anupam Goel, who serves as the VP of Clinical Operations at Advocate Health. Anupam, I'm going to turn.
Okay.
And you can share your screen and go ahead and get started.
Let me get to that point.
Okay.
So talking about reducing transcription costs using health information technology, specifically tying cost reductions directly into savings that we might be able to see separate from any other initiatives that we talk about. So a little bit about Advocate Healthcare. We're a large organization, an IDN with 12 hospitals and over 3,000 inpatient beds. In addition, we have over 250 outpatient sites of care with 6,000 physicians and advanced practice registered nurses who also are supported by several other nurses and another group of advanced practice clinicians. So what was the problem we were trying to solve? We were really focused on inpatient transcription costs. And so the sum of all dollars that advocates spent on transcription costs as well as voice recognition technology exceeded $6.5 million in 2014. And we could carve that out into $3.5 million for transcription costs and $1.2 million for voice recognition software. And we were faced with, like everyone else in the healthcare industry, challenges around producing more value for the dollars that we spend. When we started the project, every hospital site had their own transcription contract and their own conversations with the vendors about how to manage the costs of voice recognition as well as transcription. The suggestion was that as voice technology had improved, could we think about using transcription reduction as a way to help reduce documentation burden and reduce the cost pressures to make cuts in other places? Back in 2014 and 2015, people were more and more comfortable using mobility and voice to get their work done. People felt okay talking to Siri. People felt okay using their phone to do many of their tasks outside of healthcare, and most notably to us, banking, which was, in some ways, a very high-risk endeavor. Secondly, the voice recognition technology had improved to the point where most clinicians felt comfortable that it could be a possible substitute. There are two domains here. One is for many physicians or other healthcare practitioners where English is not their first language, the technology had improved enough to catch those accents that were not familiar to older versions of the technology where it could actually accurately transcribe. Two, most of the major vendors had done enough work to tune their software specifically for medical terminology to help capture words that are specific to the medical domain and help capture those terms more accurately than before. And then finally, at Advocate, I suspect, across other health systems across the country, iOS smartphones became a physician status symbol. If you had another device, that was okay, but you weren't considered a real member of the medical staff unless you had an iPhone. the iPhone 5s were big back in 2014. So part about how do we get this work done in a way that makes sense and uses technology in a smart way. So we were able to work with our EMR vendor who had developed a product that used voice recognition behind the scenes within a mobile application. And that conversation, that transcription of voice to text within the mobile device would go directly into the EMR, into that patient's record. In some ways, a small innovation from a technical perspective, but a use of technology in a way that removes the need to find a tethered microphone at a desktop or to type directly into the computer. So I picked on transfusion. This didn't require a whole lot of consensus building. People, once they saw a colleague using the phone to enter notes, they said, I want it too. So that was really interesting. Two things I want to speak to specifically around challenges you may have at your organization would be, why would any physician or other advanced practice clinician stop using a telephone transcription service that requires less effort than reviewing a document created by voice recognition? So from the physician's perspective, entering a transcription or a note via phone and having someone else cleaning up is infinitely faster than having a clinician speak into a computer system, look at the text, and then make some edits based on what was received. It turns out that transcription is considered a physician satisfier, and why would anyone want to take that away from having clinicians think that their hospital has offered amenities that we don't want to remove? So those are 2 points I want to cover over the course of this talk. This is a standard health adoption or any behavior adoption. You can think about innovators who are really early comers, and I suspect most people in the audience refer to this group. We tend to test technology early and want to use it for interesting applications. We will put up with lots of bugs in the system, but if you expose that to other groups, they may turn it off and never come back to it. Early adopters are probably the physician champions that you want to capture for physician projects, nursing champions for nursing projects, and other clinicians for those respective disciplines. The early majority would be the group that you want to make sure are on within the first 6 months to make sure that you have enough momentum to keep pushing for additional changes to optimize the system. At some point, you've got to do some work to get additional users on that late majority. And then finally, to move those laggards, you probably need something a little more forceful, like a mandate, to get them to change their behavior. We wanted to really pinpoint more users after that transition between early adopters and the early majority. So what do we think? We thought these 4 factors were the most important to drive adoption for this specific project. First, it is clear that looking for a desktop computer to enter notes is worse than entering a note on your phone. So that advantage of having that there was really nice. I think another piece of this was that it's often more difficult to find a telephone and enter dictation number than to dictate your note into a phone. So that felt like the technology had an advantage over the other existing options for getting notes completed. Compatibility, complexity, we've got to thank our EMR vendor for this. They did a great job making sure that it was relatively seamless to find the patient and open a note that could then be used as a template to enter information that's faster or as fast without having to learn new codes or new sequences of tasks. Observability, what was nice about this is we didn't have to go show this to everybody who was interested in doing this technology. We were able to seed a few early adopters to say, can you go and use this in your daily rounds? And in the process of them doing their work, they were exposed to many other people who said, wow, I can see that, I like it, and it's easy. The 4th piece is also important, this idea of trialability. So under no circumstance do we say you have to do all of your notes through the phone. Could you try some of it on paper or some of it by telephone dictation and then some of it by computer and see what works for you? And so we found that that ability to trial it and then come back to it was very powerful. For many users, they wanted to use it at the end of their day, and then as they got more proficient, they would use it for additional use cases. I think we started with working from the top to say we want to make this financial case to say rather than cutting nurses or reducing salaries, can we focus on reducing transcription costs as a start? We were able to address specific barriers for site influencers, trying to get those people who we think would have to spread the word. We want to make sure we addressed their barriers. We wanted to push the technology on the early adopters first, and we were able to identify them at each of the sites and across specialties. Another piece that was critical for us was developing regular reports to identify these high performers and saying, let's raise them up and identify them accordingly, and maybe peers would say, hey, I want to do that too. And then finally, for those laggards that we talked about earlier, we wanted to communicate a timeline that says we are going to stop telephone transcription for specific note types. In this example, it was a progress note. How do we set a goal for ourselves to get this done? So I mentioned the high cost of transcription and voice recognition for 2014. In 2015, what we did is we just looked at the first month of transcription costs, and we said, here's a number, and it's a fair bit. It's not quite, that number 4.28 was actually dropped somewhat because the vendor had made a second deal with us to reduce the per line transcription costs, so that's what that's all about. So we looked at that number and said if we blow those transcription costs and magnify them over a year, that's the number we come out with, is 4.2. And a 20% reduction would be $3.4 million. So if we can do that work over the course of the year, we would have called the technology diffusion and adoption a success. So we think that there are different workflows based on the note type that's used. We believe that opera reports are probably the simplest. We have a surgeon who does a procedure, they step out of the room, and then dictate or use voice to phone to enter that opera report in real time between cases. A more complex workflow would be progress notes, where you know the patient pretty well and you've actually written a note prior. Now you're using the voice to enter unique characteristics of the patient or the assessment and plan that you want to update from the last note. The most complex workflow would be H&Ps and consults. Here, in many cases, you're seeing the patient for the first time and have to review lots of information and try to get that information into a document for future review. And so that often requires looking at multiple screens and then thinking about a case in isolation before moving to the next case. From our perspective, we don't think voice is the only way to do data entry. We think that the most optimal way to get clinical documentation completed is actually a combination of using specific templates with prompts for things that require billing or normal information like medications, with opportunities for free text content. And the way we frame this is that if we want to prompt users to enter something, just give them a heading with a blank. For example, don't forget estimated blood loss in your op report. And so just have that heading available to let the user speak that in whenever they get to that space. So we don't imagine many users going directly to data entry for all cases or voice for all cases, but maybe a hybrid based on the workflows we talked about earlier. What means is how do we help our site support teams continue the journey to move away from telephone transcription into voice recognition? So what we found was, what can we do? And we had online FAQs. Here's a screenshot of what one of those looks like. How do you get users to do this? If they see an error, what do you do? How do we get you to project this to larger screens if that's necessary? So we found that these types of FAQs online were an opportunity for us to take learnings from each of the sites and distribute that back to everyone in a way that they could access conveniently. Identifying users and targets. So in addition to giving our support teams that FAQ stuff, we also gave them reports monthly about how well they were doing. From the corporate side, we really thought focusing on the top 10% of users from a volume perspective would be the most effective way to distribute this information. What we found was each site had a different personality or culture to get transcription reduction to occur. And so the number of users in some ways wasn't as important as seeing the numbers month after month and identifying those sites that actually had made it to the cost target. Here's an example of someone back in September as we approached the end of the year where 5 of the sites actually reached their cost target and then there were 4 left. And so by the end of the year, most of the sites had reached the target, but showing this month after month provided the necessary motivation and potential competition among support teams to get their transcription costs lower. So on the website, we also identified the top users, and we identified new users in bold from week to week in terms of orders entered and notes. And for this conversation, we want to focus on the right column, the notes. If people kept using the system, and what we found was as people learned about our technology, they kept using it more and more, and so we became inured to the fact that people would use the same stuff over and over again. And it was really critical for us to identify new users every month to say, hey, here's a new person to identify as a winner or someone who we want to keep moving forward. So week after week, in addition to the monthly transcription costs, here's a slide showing in the green line the number of notes entered week after week after week. We also have a normalizing variable, the number of providers who are on the technology, so we were able to track this week after week. And so, a couple of slides here that talk about the progress, and what you'll see is in the first few months it went a little slower than we'd like. It was from 4.28 to 3.98. And then we gained some speed. As you go further down the month, we got to 3.7, 3.5, 3.4. It was actually quite exciting, and we could follow that graph underneath where you can see the number of notes goes up most weeks back after back. It wasn't quite the hockey stick, but we did see significant improvement. And once we reached that critical mass in our perspective, when we said we think we've got over half the users that we expect to have on the technology, let's stop the progress note transcription. And so that occurred September the 1st. And so what you'll see is it turns out that times very nicely with our own internal goal of 20%. And we kept going. We kept seeing reductions even after that hard fix of turning off telephones. I will say it was surprising to us that in some ways those laggards often became our highest proponents. They said, we're not going to change until the mandate comes out. And once the mandate came out, they flipped to have all of their notes put in using the technology, which we were very surprised by and ecstatic. It turns out at the end of the year, we ended up with a spend of about $2.24 million, which is about a 50% reduction over January's estimate. So we were over the moon by how well this was adopted across our different sites. Since the end of 2015, and even as late as August of 2017, our monthly transcription costs project out an annual spend of $1.8 million. So we're really thrilled. The technology just hasn't been deployed and stepped away from. People are actually continuing to see savings based on watching their peers use it and then adopting it for themselves. It's really a challenge to get more EMR adoption across different types of tasks, but for physician documentation or provider documentation, it can be a journey. What we found was sometimes the technology would stop working. It was based on a cloud technology, and if the servers went down, then the vendor would say, oh, sorry, they're down. And if they went down during busy transcription hours or busy documentation hours, our users would be furious. We actually had some physicians walking in the hospital president's offices saying, you've got to fix this. It's now impeding my ability to get my job done. Places inside of our health system where the direct voice into phone, into EMR was not enabled, and so that was a pain point that we weren't able to address over the course of the project. But if we want to see further reductions in transcription costs, it will take some focus in that specific area. There was this perception that the notes that were entered by voice recognition were lower quality than notes entered by telephone dictation. And so that was really conversations we needed to have with the clinicians and comparing notes side by side to say, even though the technology works, it's only as good as what voice comes in, and affectionately known as garbage in, garbage out. There was also users, and so when we think about additional note types to lose, although opera reports are probably the simplest workflow to address, they represent in some hospitals the highest revenue sources and lots of concern about alienating those users who may then say they want to go somewhere else to do their work. I think from our perspective, it was critical to get the senior leaders engaged early, and we were able to pay for the technology by promising our financial leaders that we would use the transcription savings to pay for additional licenses. We were able to identify clinical champions who used it and then spoke to their colleagues to say about how valuable it was to use this system. We were able to work with site leaders to show the technology and have users try it out in public meetings and private forums to see if it would work. This idea of trialability, to say, can they try it before and after? Can they give it for part of their day, not their entire day? And you could always go back if you weren't happy. We found a lot of value from providing feedback from a financial perspective as well as a usability perspective to say, here are the dollars we've saved so far. Here are users who are still using transcription to a high degree that may benefit from technology. Is when the majority of users made the switch, making that hard stop to force the adoption. I think in many ways, if we had let it become an option, people who used it would always use it, and people who didn't would not. And we would not see the persistent reduction in transcription costs if we had not done that. Arnaud, I'll pass it back to you.
Well, thank you. Great presentation, and looking forward to listening to it again. Find folks where to go find other great presentations like this one. You can that information can be found at the HIMSS Davies website at hims.org/Davies. There you can find this recording and other and information on how to apply for Davies Award as well. So thanks again, and looking forward to the other two recordings.